Welcome to my TED Talk. My name is Taryn Niemeyer, and today I will be talking to you about urticaria. Raise your hand if you have ever had hives. If I could see you, I would assume most hands would be raised. Urticaria, commonly referred to as hives, welts, or wheals, is a common disorder that many people experience at least once in their lifetime. Urticaria is raised areas of edema and erythema with clear borders involving the dermis and epidermis. It is often transient and intensely pruritic. Urticaria is not a single disease, but rather a reaction pattern caused by allergic reactions, infections, and exposures. Let's dive into the pathology and etiology. Urticaria can be caused by a type 1 hypersensitivity reaction. Type 1 hypersensitivity reactions are IgE mediated. During this reaction, IgE antibodies attach to the mast cell. When the mast cell is exposed to the allergen, it releases pro-inflammatory mediators such as histamine. Histamine is an H1 receptor that causes bronchoconstriction, resulting in difficulty breathing. Histamine, leukotrienes, and prostaglandins cause vasodilation and permeability of the blood vessels, resulting in the swelling, erythema, and itchiness seen in urticaria. Etiologies of IgE-mediated urticaria include foods like fish, shellfish, eggs, tree nuts, peanuts, milk, and soy, drugs like penicillin and cephalosporins, insect venom such as bee venom, inhaled pollens, mold and animal dander, blood products, latex, exposure to heat or cold, and physical or emotional stress are also etiologies. Urticaria, as an IgE-mediated type 1 hypersensitivity reaction, occurs acutely within 2 hours of exposure. No etiology can be found in 30 to 50% of patients who present with urticaria. According to UpToDate, viral and bacterial infections are associated with 80% of cases of acute urticaria in pediatrics. In this case, urticaria can present with the infection when antibiotics are administered or several weeks after the infection is resolved. Urticaria can also occur through non-IgE mediated histamine release. This reaction is non-allergic and often associated with autoimmune disorders or other systemic disorders. Now let's talk about the epidemiology. About 15 to 20% of the general population experiences acute urticaria at least once in their lifetime. Chronic urticaria occurs in 2 to 3% of the general population. The duration of acute urticaria is less than 6 weeks. More than 2/3 of cases of new onset urticaria will resolve in this time frame and often resolve within 1 week. In chronic urticaria, signs and symptoms appear 2 to 3 days a week for more than 6 weeks. Chronic urticaria is more common in women than men and is most likely to occur between the ages of 40 to 60. When a patient presents with new onset urticaria, the most pertinent questions to ask are when the urticaria started, whether the patient has any known allergies, and whether there are any other symptoms associated, such as difficulty breathing, angioedema, facial swelling, or lightheadedness. These are symptoms of anaphylaxis and need to be treated immediately with an intramuscular epinephrine injection. Once anaphylaxis is treated, or if the patient does not have any anaphylactic symptoms, the provider can continue with their assessment and pertinent history questions. Other pertinent history questions review the events in the hours before the urticaria occurred. These questions include: have you felt ill or traveled out of town recently? Did you start any new medications or supplements? Do you have any insect stings? Did you eat any new foods? Were you exposed to temperature extremes or dramatic shifts in body temperature? In a patient with acute urticaria without signs of anaphylaxis, they will have well-defined raised areas of edema and erythema in a local region on the skin or all over their body. The urticaria can also be transient, meaning it can disappear from one area on the skin and present in a different area, sometimes in a matter of minutes. The patient will most likely be complaining of extreme itchiness. However, the more the urticaria is itched, the worse it gets. If a patient has urticarial vasculitis, they will also complain of pain, usually a burning sensation and tenderness of the skin lesion. Urticaria is diagnosed based on the patient's pertinent health history and physical presentation. A diagnosis can be made without a known etiology. New onset urticaria without signs or symptoms of systemic involvement does not warrant laboratory testing. If urticaria presents with systemic symptoms, laboratory testing is indicated. Recommended serum tests include complete blood count with differential, serum creatinine, erythrocyte sedimentation rate, and C3 and C4 complement studies. The patient can also be referred to an allergist who can do further testing to possibly determine an etiology. Urticarial vasculitis is an inflammatory condition of the blood vessels, causing urticaria and is more commonly associated with chronic urticaria and systemic disease. Urticarial vasculitis differs from common urticaria because it is usually painful, causing burning and tenderness. It is not transient and often leaves bruising after the urticaria resolves. If urticarial vasculitis is suspected, laboratory testing and skin biopsy need to be done. Systemic diseases associated with urticarial vasculitis include autoimmune diseases like lupus, malignancies, and infectious diseases like hepatitis B and C. Now let's look at complications. The most common patient complaint from urticaria is the extreme itchiness. If urticaria is a symptom of anaphylaxis, intramuscular epinephrine needs to be administered immediately. Complications of untreated anaphylaxis include chest tightness, difficulty breathing, nausea, vomiting, abdominal pain, angioedema, hypotension, and death. Urticarial vasculitis can cause itching, burning, and pain, and lesions can cause bruising. As stated prior, further testing needs to be completed to identify the underlying cause of urticarial vasculitis in order to treat it and reduce complications. Treatment and management of urticaria begin by eliminating the cause of the reaction if known and possible. Acute urticaria will resolve on its own with or without treatment. However, pharmacological treatment is recommended for symptomatic relief. H1 antihistamine therapy will provide short-term relief of symptoms like itchiness. Second generation H1 antihistamines are recommended as first-line therapy. They produce the same effect as first-generation agents with fewer side effects, reducing drowsiness and minimizing anticholinergic adverse effects. Oral formulations are typically administered at standard dosing. They are also safe for children in smaller doses. Treatment should continue until lesions have completely resolved. If the patient continued to have recurrent urticaria episodes of hives 2 to 3 days a week for over 6 weeks, they are considered to have chronic urticaria, and dosing is increased to 2 to 4 times the standard dose. According to UpToDate, glucocorticoids are overprescribed in acute urticaria. Glucocorticoids, like prednisone, should be reserved for patients with persistent symptoms or prominent angioedema for several days after regular administration of H1 antihistamines. If a patient needs glucocorticoids, prednisone is prescribed for adults and prednisolone is prescribed for pediatrics. The patient should be educated to continue antihistamine therapy during and after their course of glucocorticoids, because some patients experience an exacerbation of the urticaria as the glucocorticoids are tapered or discontinued. Oral H2 antihistamines, topical antihistamines, and topical corticoid steroids are not recommended in acute urticaria because there is currently no evidence that these medications are beneficial in relieving urticaria or associated symptoms of itchiness. To summarize, urticaria is a common skin disorder presenting as transient edema and erythema on the skin with a well-defined border. It is commonly referred to as hives, welts, or wheals. It can be acute or chronic and caused by many different etiologies. It is diagnosed through a pertinent health history and physical exam and often does not need laboratory testing. Acute urticaria often resolves on its own, but second-generation H1 antihistamines can be given to reduce symptoms. 3 important takeaways to remember are: first, when a patient presents with urticaria, assess for signs and symptoms of anaphylaxis. This is a medical emergency and needs to be treated immediately with an intramuscular epinephrine injection. Second, differentiating between urticaria and urticarial vasculitis is important because it affects the testing and diagnosis of the underlying cause. Third, patients can be reassured that acute urticaria often resolves on its own within a week, but oral antihistamines can be given to reduce symptoms. Other medications, such as glucocorticoids, H2 antihistamines, and topical agents, are not recommended in non-systemic acute urticaria. Thank you for your time. Again, my name is Taryn Niemeyer, and these are my references I use for this presentation.